You know, it's funny. I didn't make that. Don't applaud. You know, what's really funny is that growing up, I'd watch that and I'd be like, that is incredible. That's going to happen, you know, when I'm 100 years old. But watching that video now, it's like that stuff's kind of already happening, right? People are already having implantable eyes and the bioprostheses, and soldiers are wearing exoskeletons. So it's amazing. The future is now. So what we're going to talk about today is just this type of thing. We're going to talk about the $6 million man or woman. And, you know, this is amazing stuff that's happening. We're getting all these patients with implantable technology. And as Stuart Swadron always said, I love this quote, is that you need to know what you need to know, and you need to know one step further. So as this technology is being put into people, people are going to come in with problems, and they're going to come to your emergency department saying, hey, guess what? You know, I have this. And if you're not ready to handle those patients and their problems, you're going to be in trouble. So I'm going to give you some of the more recent devices and some of the more common problems that we see in the emergency room, and hopefully that'll give you a little bit of a basis, not only to evaluate those patients when they come in for other things like an ankle fracture, so you kind of know what's going on with them, but also when those actual devices go bad. So, random case, there's a patient that comes in with chest pain, 45-year-old. The nurse goes to evaluate them, and the patient has no blood pressure and no pulse, but the person's just conversing with her. And the nurse comes screaming out of the room and grabs you and says, I need you in the resus room right now because this person's dead, but they're talking to me. So this is when a VAD goes bad. How many of you folks have seen left ventricular assist devices? Show of hands. Okay, you're going to see a lot more of them if you haven't seen them already. And what this technology is basically replacing the left ventricle, putting a pump, a mechanical pump within the heart to fix ventricular function such as this one that you're seeing with this left ventricle is barely working. It's just basically a muscular tube that's connected to the aorta. These devices are getting so small, these tiny little motors, and they pull blood out of the ventricle and push them into the aorta. There are three broad indications for patients that get VADs placed. The first one is someone that has a reversible disease. So a young person that comes in with some really bad viral myocarditis. You could put a VAD in, allow the heart time to recover, and then explant that VAD. Another indication is people who are waiting for a heart transplant. You know, they've been sick, and now they have an acute illness that makes them sicker, and they're still on the list for transplant, but they're just not well enough to get to that transplant. So they may put an LVAD in, and they may survive for a while until that transplant becomes available. And this is becoming a more popular option. This is called destination therapy, and this is for people that are either not transplant candidates or say, you know what? I don't want to take all those transplant meds and be in the hospital all the time. I'll just have the pump and take my chances. So it's a destination therapy. I'm not sure what the destination is, but that's what it's called. The most famous person with them as to date is Bill Cheney. He had one of these, and this is a popular photo where he's showing his battery packs that these patients wear. This is essentially how it works, this quick little video. Right here what you see is you see this LVAD pump that sits here in the abdomen. This is a newer generation device, and this is the inflow cannula. They basically bore a hole in the left ventricle and pull the blood out, gets pumped through this pump, and goes up into the ascending aorta. That's how it works. It's just that simple. And it's a linear flow, and it's non-pulsatile, and that's why the patient has no pulse, okay? Because it's a linear flow that just keeps going through the heart in one steady rate. Patients come in, they may have battery packs on. You have two batteries here, one on each side, that powers this controller. Now this controller runs the energy through this thing called a drive line that goes through the skin into the LVAD to power it. So they come as a complete package. You have the LVAD, the drive line that goes into the controller, and the controller comes with battery packs. So here you see the LVADs sitting here. There's different types of LVADs. This LVAD sitting in the abdomen with the pumps that extend through the diaphragm into the heart. This one is also one that sits in the abdomen. And then older devices here, which sits actually in the ventricle and sits in the thorax itself. So you may see different things on x-ray, and this is just a familiarity with them. So you get the phone call that this person's coming with an LVAD, sick or not. The first thing you have to tell the patient or the paramedics is make sure they bring all their cords. Because if they're coming to a hospital, your hospital, and you don't have those cords available, you won't be able to charge them up. I mean, essentially, these patients have to stay charged. The next thing is that you have to be sure that the patients bring their batteries. Now, most of these patients get it. You know, they're well-versed before they get this LVAD implanted, and as well as their families. They know the routine. They know they have to get all their cords together, put them in a bag, and their batteries. But you still should remind them. And the very next phone call you should make is call your cardiac surgeons or call your LVAD coordinators, or even sometimes they have these engineers that come and titrate the LVADs. You need these people to be on the way to the emergency department because there may be some subtle adjustments that you have to make the machine that you may not be able to do on your own. So call these people into the hospital immediately and have them ready when the patient arrives. When the patient comes in, the first thing you want to do is you just want to listen to them. You're going to hear a hum, this low-sounding and that just tells you that the VAD is working. That's a good thing. If you don't hear the and the person's not responding, that would be a bad thing. The next thing is you want to check a blood pressure. Now, conventional cuffs won't work. This is a linear flow device, which means it's a propeller, like a speedboat. So it's just one continuous flow. If you look for that, the systolic, what is that called, the Korokov sounds and all that, you're not going to hear it because it's a linear flow. So you check the blood pressure by using a manual cuff, if you can find in your department, and putting a Doppler signal on top of the artery. And you inflate the cuff over your systolic pressure and slowly release. And once you start hearing a Doppler flow again, you're going to use your mean arterial pressure. That's all they have. Sometimes they may have systolic and a diastolic flow as the heart recovers a little bit, some contractility. But if you don't hear anything, it's okay. It's a nonlinear, non-pulsatile. It's a linear, non-pulsatile flow. So just listen for the map. The next thing you want to do is inspect the drive line. That thing is coming out of their abdomen, and it can get infected like anything else. So you want to be sure that you look for any signs of pus or erythema. So inspect that carefully and feel for tenderness. And the next thing you want to do is look down at their controller. It'll have a battery indicator light, and the patients will tell you what to do as well. And then you want to feel it to make sure that it's not too hot. If it's too hot, that means that there's some pulp malfunction, there's some resistance in the circuit. This is all part of your initial assessment. The target blood pressure here, 70 to 90 is the map. And this varies by device, but the more recent, the newer generation devices look for a map of 70 to 90. You could continuously do non-invasive cuffs, but if you're going to have this person and they're sick and they're staying with you for a while, consider putting in an A-line because it'll give you continuous blood pressure measurements, and so you don't have to keep running back every time their clinical condition changes and inflate a cuff. The other thing, besides hypotension for these people, is hypertension hurts these people. Now, we all get hypertensive people in our departments, and we know that they have time, and you don't have to immediately rush and decrease their blood pressure. But these people, you do, because you have a lot of afterload on a pump, and that pump is going to start failing and malfunctioning. So decreasing the afterload for these people is actually critically important. So, it's like Goldilocks. You don't want the blood pressure too low, and you don't want the blood pressure too high. For these devices, you want a map goal of 70 to 90. And if you're unsure of what device they have, you'll be on the phone with the coordinator, and the coordinators know all this information. So what happens when your VAD goes bad? Let's talk about some bad things. Well, the simplest thing that you'd see is these patients have some anemia. This is a continuous motor that's flowing through, and it's just chewing up red cells as it goes. Now, most patients will tolerate it, or if they go to their outpatient clinic appointment, they'll recommend a transfusion. But they can have this baseline anemia that when they have things like bleeding can really cause a problem. And so that's the second big complication. It's probably the biggest thing we have to worry about is bleeding complications. Now, bleeding happens for a variety of different reasons. The first reason is because they have this acquired von Willebrand's deficiency. And just to be really simple about it, as this von Willebrand's molecule, which is a very big molecule, goes through these rotors, it gets clipped around and it becomes ineffective. So now you have ineffective von Willebrand's factor from that pump. The other thing is that these patients have to be anticoagulated. You can imagine that they have blood flowing through a motor, so the blood has to be thinned out, and so they're often on Coumadin. And their INRs can be anywhere from 1.8 to 2.3 or up to 3, or they can just be super therapeutic, like every patient that we have that's on warfarin. So be aware that these patients may be anticoagulated. And they can come in for things such as minor things like mucosal bleeding or hemarthroses, or they can come with massive GI bleeds. Another complication, as if that other stuff wasn't enough, is that these patients can develop intestinal AVMs. And they don't know why this happens, but it's a complication. So these patients can have GI bleeds that even after you reverse can still continuously bleed. So these can be problems. You could have intracranial bleeds. And how do you treat these people? You just give them blood product. You want to reverse them as fast as possible. Don't worry about acutely reversing someone with an LVAD. If you get that INR and make them hypercoagulable, it's not going to clog up the LVAD acutely. You have time. So if they're bleeding, go ahead and reverse them, and then they can always be started on a heparin drip after that. Transfuse them as you normally would, and give them platelets as necessary. Vitamin K is very important if this person is over anticoagulated with warfarin. And then certainly you can give them DDAVP. These patients also can develop infectious complications, certainly from the driveline, because now you have something from the outside with a tract going right inside the thorax. You can get mediastinitis, really nasty infections. So be sure that you inspect and palpate that drive line. You can also have this thing called vaditis, okay? What do you think that is? Infection of the valve, of the VAD, right? Because this is an implantable device. Bacteria can see that device, and you can get infections. And these are really, really troubling diseases to take care of. You're not going to explant the VAD in the ED. Don't worry. That's not a procedure we're going to talk about today. But you are going to get this person on broad-spectrum antibiotics and call your cardiac surgeons, and they'll have to decide whether or not they want to treat through this infection or will they explant this patient. And then finally, where the VADs actually sit in the pocket, those can become infected. So your person who has a VAD might have abdominal pain, but their VAD might be sitting in an abdominal pocket in some generation of devices. So you want to palpate that area, and you may have to go for CT scan just to evaluate if there's a pus pocket in there. Broad-spectrum antibiotics for these people. They're in the hospital, they've been admitted, they're in and out of hospitals all the time. So you want to cover for MRSA, especially because they have the exposure with the drive line. So they have cutaneous infections. And then gram-negatives because they're in the hospital, they're high risk, but also because they have pockets that are sitting in the abdomen. Here's an example of someone who just had their pocket infection opened up, and they're just doing exploratory laparotomy. So someone comes in, and their blood pressure is okay. Now remember, this LVAD is working, it's pumping continuously. It almost doesn't matter what the heart is doing. So someone can come in an arrhythmia and actually have a normal blood pressure. And that might be okay for the time being, but remember, their left ventricle might not be working, but their right ventricle isn't working as well now too. So if the right ventricle isn't filling the left ventricle, you may eventually have problems. So patients that come in like this need to be cardioverted. And whether you do it by electricity or pharmacotherapy, it doesn't matter, but you need to get that RV back to normal because that person won't last very long. And you do what you normally do. We know ACLS. You're going to send certain labs. Initially, when you see these people, certainly a CBC for the anemia, for the platelets. You're going to send an LDH, and this is going to help you if the person's shearing up a lot of blood and they're getting anemia from that. And then blood cultures if you suspect infection. INRs as you normally would. Lactate levels if you think they're septic. And a troponin. You can use ultrasound as well to help evaluate these patients. And essentially what you're going to be doing is looking at the right ventricle. With that pump sitting in there, you may not see much, but the right ventricle you can see very well. And if you have a very small right ventricle, you could have something called suck-down phenomenon, which basically means there's not enough volume inside the heart, and the RV can't fill the LV, and the LV is just sucking down on the VAD, and actually that inflow can have some myocardium pushed up against it. So consider early volume for your patients. Even if your person looks a little sick, just give them a liter of fluids anyway. You probably won't harm them. But remember, this is a phenomenon that can happen. So this is a challenging, and I won't have an answer for this, but what about the person who's flatline, cardiac arrest, who's actually out cold now, they're not talking to you, they have no pulse? What do you do for that patient? The first thing you want to do is you want to get to that device controller and make sure that the batteries are in there. Believe it or not, there have been cases where people's batteries become unplugged or the batteries out of charge, and if the batteries have no juice, the VAD's not working. So that would be the simplest fix. The next thing is you want to feel the VAD. If the VAD feels like it's a normal temperature and the batteries are all lighting up, well, that means that everything might be working okay with the VAD, and listen for that hum. If it's hot and you don't hear the hum, now you have a dilemma, because now you have a pulseless person with no rhythm and no motor working. What are you going to do for this person? Now, Dr. Matu spoke yesterday and said, if you really want to make a cardiac surgeon mad, give them clopidogrel before their cabbage. I have another trick for you. If you want to see a cardiac surgeon's head explode, do CPR on a patient, or tell them that you do CPR. Okay, we lost one cardiac surgeon that way. He said, just blew right up. The reason why it's so dangerous is because that's sutured in that apex, and doing CPR will dislodge that cannula. Now, the manufacturers will say clearly, please do not perform CPR. But I ask you this, if you have a patient that's sitting there pulseless, their VAD's not working, how many of you are just going to sit there and be like, well, they told me not to do anything. You okay, sir? Nope, it's not alive. So it's a conundrum, and I don't know what to tell you the right answer is. If you're in a place that has a cardiac surgeon on the way, I would just ask them. If you're in the middle of nowhere and you don't have a cardiac surgeon and you want to initiate CPR, I think that's reasonable. I don't have a good answer for you. Someone else might come up here and say, never do CPR. If they die, they die. So that's what I have for you. No answers. How do you like that? All right, so essentially remember this. The more common things that you'll see is patients coming with bleeding complications from the von Willebrand's factor, infections, Do what you normally do, cardiovert them if there's any right ventricular arrhythmias, and CPR is still very controversial. Okay, let's move on to complications with dialysis lines. Okay. So there are three types of lines that you're familiar with. There's the tunneled line, and this is going into the right near the right atrium, and here's a cuff right here. These are just temporary lines for people that acutely develop renal failure, or they're waiting for their AV fistulas to mature. These have the highest rates of complication. As you can imagine, they're percutaneous, and it's a nidus for infection to track back. The next type is a graft, and this uses Gore-Tex material. This is surgically implanted, but you're ready to go right after the OR. This person has a loop, and this is the way you can distinguish between a fistula and a graft, is you'll actually feel a loop coming around here like that. They have a lifetime, they're about 2 years, and they have less complications than the percutaneous lines. And then finally, there's the fistulas that we all know. These take time to mature, so someone goes to the OR, it'll take about 3 months for that native fistula to mature so that they can use it percutaneously. In the meantime, they may have a dialysis line. The lifespan on these are about 5 years, and these have the least complications. So here are some problems that happen. 3 classes of problems. You can have bleeding, you can have infection, or you can have stenosis or thrombosis. Infections, we see these all the time, and we always know when a dialysis patient comes in, some nonspecific complaints, this is high on their list, right? They're essentially getting stuck all the time, and they're getting a little bit of bacteremia with each session, so it should be really high on the list, and their symptoms may be nonspecific, so you have a high index of clinical suspicion. And the highest rates of incidence are on the tunneled line, and just because it's not having pus or tender, you should still put these pretty high in your differential. Bugs to consider, obviously the skin flora, think about MRSA, regular old Staph aureus, Staph epidermis, and then gram-negative organisms, because these people are always in healthcare situations. Send your usual bloods. Nothing abnormal here. Send your blood culture, send a lactate if you're resuscitating your people, and get antibiotics early on, right on board. And you probably only have to do 1 dose because they're dialysis, and so that antibiotic will stay on board. Give them whatever MRSA drug you want, whatever gorillacillin you want to do. Moving on to thrombosis, lack of a bruit, lack of a thrill. Sometimes the patients will come and tell you this. Sometimes they may have some distal ischemia and tell you. This is an urgency, not an emergency. You know, sometimes we get worked up because, oh my God, we think it's an acute limb. You definitely want to get your vascular surgeons or IR or someone involved, but they don't immediately have to be taken to the OR right at that moment. You have some time. Get your consult early on, and if you need dialysis acutely, you can do femoral access. This way you're saving the upper extremities should they need any other interventions later on down the road. And the same is true if there's some stenosis, which can happen with trauma, hypercoagulable states, hypotension. You have time. Certainly you want to make the phone call early, document who you spoke with, but you have time. It's an urgency, not necessarily an emergency. So let's move on to the big complication, the thing we hate, bleeding. Now, patients who are on dialysis bleed for a variety of reasons. The first thing is their circuits are heparinized, right, to make that blood slippery, slide through the circuit. They're uremic at times, so the platelets don't act as well. They're not as sticky. And finally, they also have comorbid diseases, right? They're on Plavix for different reasons, aspirins. They're also on warfarin for clots. So these people at baseline are at a higher risk of bleeding. So what do you do for these people? Just put pressure when they come in, right? They get stuck in the same place over and over. Just have them apply pressure, and don't be satisfied with the gauze and then the Curlex that goes around. That's not enough pressure. You need to actually apply pressure to the patient's bleeding site. Now you're going to say, I'm busy, I got things to do, and I get it. Have the patient's family member or have the patient, if they're cognizant, sit there and hold pressure and ask them not to peek. You know, it's like epistaxis. It's like, don't peek. Don't see if it stops bleeding. When the big hand is on this and the little hand's on this, I'll come back. I'll tell you when to take pressure off. That's what you should do for these people. And if you do that, most of the time, you'll stop the bleeding. You can also add things like gel foam or thrombins to actually have some local coagulation. You can just prophylactically give these people DDAVP. There's little harm in that. And then you can resuscitate them if you need with FFP and protamine if you think that they're over anticoagulated from warfarin, or if you think the protamine's still circulating around from the dialysis circuit, and that's the reason that they're bleeding. Go ahead and give them protamine. If they're really bleeding, exsanguinating, life-threatening things, then it's okay to go ahead and put a tourniquet to stop the bleeding. You have to stop them from exsanguinating while you're on the phone with your consultants, and usually it's going to be vascular or general surgery, and then resuscitate them as you normally would. So you have infection, bleeding, and stenosis and thrombosis for your 3 different types of catheters. All right, the last thing we want to talk about is these things. When your ticker makes you sicker, right? What's this thing sticking out of this guy's chest? These things are amazing, pacemakers and defibrillators. They're getting so small, the technology is getting so amazing, they're getting so cheap. They're putting them in everybody and anything. I mean, they're even putting them in dogs, okay? And I went to our local veterinary clinic up the street from us, and I saw their recovery room, because this is where this is from. This is how they're recovering the animals after their procedures. It's incredible. It's incredible. I'd never seen a patient treated this way, but so if you're a dog, you're lucky. But getting back to this, the technology is pretty cool. So the pacemakers are for when your heart goes too slow, and the defibrillators are for when your heart goes too fast. Let's talk about pacemakers first. Put them in for Brady syndromes, where you're symptomatic bradycardia. You can put them in for patients that have syncope due to rate-related problems. The device, or the can is what it's called, has circuitry built within it. It has a battery, and then it connects to leads that actually go into the chambers, either the atria or the ventricle, or both. Now, there's an EKG ability for most of these for all these newer devices, so every pacemaker can do EKGs, but some cardiologists will elect to turn them off. Not because they don't want to read them in their office. It's because to save battery life. So you can actually increase battery life by turning these off. So some cardiologists will elect to turn them off. And you can turn it back on by using your interrogation device. 2 basic modes for pacemakers. They can either be synchronous or a demand mode. Okay, so it'll be synchronous with the heartbeat, and when it detects that there's a loss of a beat, cause contraction of the heart. Or it can be asynchronous, where the pacemaker's just firing all the time, or a fixed mode. This fixed mode is similar to when you put a magnet over the pacemaker. Now, magnets, are pretty scary things. You're like, I don't want to hurt the patient. I don't want to put a magnet. You cannot hurt the patient by putting a magnet over them. So if the pacemaker's acting wacky, just go ahead and put a magnet over. And what the magnet does is it turns off the pacemaker's sensing function and makes the pacemaker pace at its own intrinsic rate, whatever they decided to put it on when they were interrogating or setting up the pacemaker. Okay, so you cannot hurt a person by putting on a magnet. The leads that go into the heart, you can have a single lead that goes into the ventricle, or you can have a dual lead which goes into the atria and the ventricle. Most of the newer ones are dual lead pacemakers. And so when you see these patients, you want to get a chest x-ray to sort of evaluate things. And the lead should always cross the midline as they do here. Okay, this is normal. This is going from right here, right there into the ventricle. The other thing you want to look for is how the tips are positioned. So an atrial lead should be pointing slightly upwards, and the ventricular lead should be pointing slightly downwards. And then when you do the laterals, they should be pointing towards the sternum in that same splay. The ventricle's pointing down, and the atrial lead pointing up. It's always so complicated, and sometimes I have to stop and think about this, but just remember there's 5 positions on the pacemaker. You really only need to know 3. The first thing makes sense, right? It's the pacemaker function. It's what you're pacing. So you can have a pacemaker that paces just the atria, you can have one that paces just the ventricle, or you can have a pacemaker, a dual lead, that paces both. The second position is what the pacemaker is sensing, what it's listening to. Is it listening to just the atria? Is it listening to just the ventricle? Or is it listening to both? And the final position is what the pacemaker does in response to what it's listening to. So does it trigger a beat? Does it release energy? Does it inhibit the pacemaker from working? Does it do both? Or does it do nothing? Now, most of the pacemakers that we have in the States here are DDD, so they have dual lead, dual sensing, and they trigger and inhibit. Other parts of the world, if you have patients that are traveling over, they may have VVIs. That means that the ventricle is paced, the ventricle is sensed, and the ventricle is inhibited. Ask your patients for a card when they first come in. This is going to give you a lot of information, okay? It's going to tell you what device they have implanted if they don't know, and it's going to give you phone numbers to call, because the next step is going to be to get someone in there that's going to help you interrogate. If they're out cold or they don't remember, or they lost their card somewhere, you can actually do high penetration chest x-ray, and you'll be able to see the stamp of the device. So here's a Guidant device, and here's a Medtronic. Okay, so you can just zoom in and look at this, but ask your radiology tech to do a high penetration x-ray so you can see this. And then you can call up the companies. And in fact, if you only have access to one of the companies, these companies will help out each other. Get an EKG, right? EKG is the simplest thing to do. What you see here is you see a pacer spike a long, narrow spike followed by a QRS complex. Okay, so this is a ventricularly paced EKG. When you look closer, you'll notice a couple things. The first thing is you'll always see a discordant ST and T wave change. So the ST and T wave should always be opposite the major QRS complex. The next thing, as you can imagine, if you're putting a lead in the right ventricle, you're inducing a left bundle branch block. So a left bundle branch block is a normal thing. So how do you know if this person's having an MI? Well, remember Scarbosa's criteria. Not a great amount of evidence, but in Scarbosa's original data, there was a small subset of people that had pacemakers, and Scarbosa's criteria holds up. You can also have a pacemaker going on and off, sensing beat-by-beat variation. So here we have a pacemaker that's pacing, 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 and then native beat, and then starts going into pacing again. So these devices are amazing. On beat-by-beat basis, they're making decisions with their circuitry. So here again, here's the pace beat, and here's a normal intrinsic beat with a P triggering a QRS complex. So let's talk about some specific pacemaker malformations, or dysfunctions, I should say. And there's really three big things to remember. Is it a failure to capture? Is it a failure to output, or a failure to pace? Or is it a failure to sense? Is the device not sensing well? The first one is a failure to capture. And what we mean by capture is that there's a spike but no QRS complex. So there's electricity, but it's not capturing the myocardium to create a beat. And this can happen with a lead fracture. It can happen if that lead gets unscrewed or dislodged, or it could be a problem with the device. And so you see here that there's just pacer beats just firing haphazardly, not causing contraction. And here again at the bottom, you see the rhythm strip with just a pace beat here and no QRS complex. It's failure to capture, failure to get myocardium. We can also have a failure to output. And this is when you're just like, hello, pacemaker, where are you? The rhythm is slow, and you'd expect there to be a beat, but for whatever reason, there's no spikes. The pacemaker's just taking a nap. This can happen with lead fractures. The pacemaker may want to fire, but it just doesn't. It might be a problem with the device itself. There may be oversensing. So for whatever reason, the pacemaker may detect a hyperacute T wave or a muscle fasciculation, say, oh, that was the intrinsic beat. I'm going to inhibit. I'm not going to fire right now. That's oversensing. Some more examples of really slow beats here, where just you'd expect the pacemaker to fire, but nothing is happening. And then right down there at the bottom, a very slow rhythm. The final one is a failure to sense. And in this case, spikes are just happening. It doesn't sense what's going on, and it assumes that there's no cardiac activity happening and is trying to pace inappropriately. Now, the risk of this, although it's low, is R&T phenomenon. It could also be undersensing as well. This can happen when the leads get dislodged. It could be an alteration of the position, so the pacemaker wasn't in the position that it was originally intended to. And the way you fix this is you just basically put a magnet on the pacer. And here's just some random spikes right here. Just spiking, no QRS complex. It's just doing whatever it wants, and nothing is happening. So if you're unsure of what's happening, go ahead and put a magnet on it, and it's going to turn the sensing function off. And you're going to go to the intrinsic rate. And then go for the intrinsic rate and see what's happening to the myocardial activity underneath. Okay, if there's QRS complexes, maybe it's just a problem with sensing. If there's not, then maybe it's a problem with capturing. Remember, it turns it to the asynchronous or the fixed mode, and there's very little harm of doing this. But ultimately, what you need to do is you need to get either your cardiologist or the technician to come in and interrogate the pacemaker and tell you what's going on for that person in the emergency department. How about ACLS? The patient's paced and pulseless, there's no ventricular beats, patient's unstable. Just forget about that pacemaker. Just ignore it. Just do what you normally do. Assume it's broken. You might put transcutaneous pads on, keep them about 10, 15 centimeters away. Or you can float a transvenous pacer. And sometimes it gets scary because people say, well, I don't want to get the wire all tangled up inside there, and I'll pull it out and I'll invert the patient inside out when I take out that pacemaker. If the person's dying on you, you got to do what you got to do. And we're tough. We're emergency physicians, so we know what to do. So remember, problems with the pacemaker. You put pacemakers in because patients are slow. Magnet turns off the sensing. Remember the failures, capture, output, and sensing. And then finally, do what you normally do with ACLS. Let's talk briefly about AICDs. These are also pretty impressive devices. They're larger than the pacemakers. They contain battery electronics They have an antenna, a capacitor to charge up, and then they have leads that go to the myocardium. Now, defibrillators will do a couple things. They don't always shock you when they detect a rhythm abnormality. They're super smart. They'd actually start pacing really fast and see if they can overdrive the heart out of that rhythm. They may go for low energy defibrillation so they can conserve battery. And then worst case scenario, they'll go ahead and use high energy decompression because that, it's like the patient gets kicked in the chest. They don't like it. So it tries to go through this algorithm first before it goes ahead and shocks them. And then every AICD has a pacemaker function because there's always a little bit of asystole after a shock, so it'll pace the heart rate out. Now it's not going at a rate of 70, it's usually a rate of 30 or 40, a very slow rate, but it just provides some support to the heart. So here's an x-ray, you see the defibrillator coils right there. Looks very different than the pacemaker leads. Here's some more coils. You can also zoom in and get an idea of the device manufacturer. This is usually put in for prophylaxis, primary if the person has Brugada syndrome and you caught them early and you say this person is at a high risk of death, you put it for primary prophylaxis. If the person has chronic cardiac disease and they have low EFs, and so their EF is less than 30, 35%, they're at high risk for VTAC, so you put it in. And then for secondary prophylaxis, someone that comes in dead and you resuscitate them back, you put it in so this doesn't happen again. These devices improve mortality much better than any medications that we can do. So these things really do save lives. The magnet, it turns off the defibrillator function, turns off the sensing, and it allows the pacemaker function still to happen. So if you have a pacemaker that's going wacky, you could put a magnet on and then put pads just in case. Let's talk about some shock scenarios. Patients come in with shocks, we know what to do. History, physical, EKG, troponins, electrolytes. Troponins may be elevated because of the shock, but if they continue to rise up even after the shocks, that might be indicative of myocardial ischemia. And then finally get a chest x-ray to check in on the device. People one shock, their cardiologist will even tell them, don't even come to the hospital. Your pacemaker, your defibrillator did what it's supposed to do. You had an arrhythmia, you got shocked. Some patients might even have a home transmitter where they can actually hold it onto them and interrogate from home. And if you see these people, if you talk to your cardiologist, you can actually discharge them right from the emergency room in consultation with a cardiologist. I probably wouldn't do it on my own. I'd have a conversation with somebody, say, hey, Joe, can you see him tomorrow? Cool. The case is when you have multiple shocks. All these people are getting admitted, no question asked. These people don't go home. The real question you have to ask yourself is, were these shocks appropriate? Was this really VTAC or VF, or were they inappropriate? Either way, they got to come in. You want to get this person on a monitor and try and capture some of these things, but eventually they have to be interrogated anyway because they have their own EKG device within them. Here's the algorithm. If it's appropriate, you get labs, you do your normal stuff, give them your normal meds, normal antiarrhythmics, and then you get them interrogated. If it's inappropriate, you put the magnet on, turn off that sensing and pacing function because you don't want to keep having them getting shocked. It hurts to get shocked. And then get pads on and put them 10 to 15 centimeters away from them so you don't harm the device, and keep them on so should they have another event, you can go ahead and shock them appropriately, but get them interrogated. Inappropriate things, you can have from SVT, from a pacemaker, AICD malfunction, from oversensing, so they're detecting some muscle fasciculation, it thinks that there's arrhythmia, shock. That sucks. And electromagnetic interference, okay? The cell phone thing is kind of a myth, but there are still some reports that people from other electromechanical device triggering firing, and ultimately it's interrogation. So remember, AICDs go in for being fast, magnet turns off the sensing, turns off the shock, keeps the pacemaker function, and then single shock probably can go home, multiple shocks you admit them. Last thing I want to talk about is what happens with these mechanical devices. And this happens for both AICDs and pacemakers because these are complications with having a device put in or if the device goes bad. Here's a pneumothorax. Happens about 1 to 3%, usually an early complication. As they're going transvenously through the subclavian route, they can cause a little bit of a pneumo. And here's a really big pneumo. You can also have perforation of the myocardium as they're putting the wires through, and this can create tamponade, as you see here. It can also cause vascular injury, just a perforation or a complete tear. And then you can have nerve injury, most commonly brachial nerve injury, because that's in the area of the subclavian. Here's some perforations right here. You see the lead tips are not ending where they should. They're going outside of the heart. And another one right here. Here we have hemothorax, certainly can get blood in the chest, and here's an ultrasound with just some blood floating around there. So that's from perforation of the cardiac, of the heart. And here's a pocket infection. This is actually a hematoma. Hard to know when you initially see them, but you should treat it as an infection. When you have patients with infections, it could be a pocket. You can actually palpate. They could be tender. You feel fluctuance. You can look with ultrasound. Or it could be an endovascular complication. If you see someone's pacemaker, always feel it. Make sure it's not tender. There's no redness. It's not being extruded out of their body, as this other person right here. Ask them if it's tender. And you can use ultrasound, see if there's any fluid area. Don't aspirate it. Don't do any IND on it. Just leave it alone and let someone else deal with it. And you want to culture them up, blood cultures, and give them antibiotics. Here are just some examples of pacemakers being extruded from infection. These all need to come out. Same thing with this. This is a lead infection here. Patients that come in with fever and a pacemaker, it's endocarditis till proven otherwise. It's relatively a late complication, and the mortality is very, very high, so you have to treat these patients very, very aggressively. The mortality is high even after they take the wires out, so it's a big deal. This is called Twiddler syndrome right here, a complication where people consciously or subconsciously just kind of play with the pacemaker, okay? And what it does is it twists this wire around and retracts the wire back as it winds. Here's just a quick illustration. The person is winding this pacemaker, and the wires are being twisted, and what happens is these wires pull out, and they come out of their target structures. They can cause hiccuping or tickling, as now the pacemaker's firing, but it's hitting skeletal muscle, not myocardium. And here's an example with the lead, the atrial lead, that's way up here. And here's an example right here where you just see all this, there's too much slack here, and that's because this person's twisted it all the way down here. And just another example. Lead fracture is another problem here. You see this lead is fractured. Usually happens as you pass the lead under this clavicle, under the first rib, or it can happen at the insertion site of the pacemaker. As the person's moving around, that wire keeps bending back and forth. And just a couple examples of this. You see this is fractured right here. Another fracture. And another fracture right there with the arrow. Okay, and this is the last clip, just someone who had their pacemaker taken out. You may see wires without any endpoint, and it's common for people to have their devices removed and replaced with newer devices, as we have over here, but they don't take out the leads because there's more harm by removing the leads, so they'll just leave them in place. But don't freak out if you say, hey sir, did you lose your pacemaker somewhere on the way to the hospital? It's, the cardiologist took it out. So for pacemaker mechanical complications, AICDs, remember you can perforate them as you're putting it in, they can become infected, there can be Twiddler syndrome, or you can have lead fracture. So I hope I've given you the tools to identify these people when they come to the emergency department, whether they're sick or not. At least you can check in on the devices, see what's going on. There's going to be more and more amazing things that are happening, so just be aware. And remember, you need to know what you need to know, and then you need to know one step further, just as Dr. Swadron said. So thank you for your attention.